a huge gap in care is sexual and gender minority health. So I think there's a lot of opportunity, and I think we're like just the people to fill that gap.
Hi, everyone. Hello. Hey, guys.
Hello.
Hi. So everyone's tuned in. Hi, guys. Welcome to eShadowing. Hey, everyone. So my name's Rodalyn. I'm sorry for the noise in the background, but my name's Rodalyn. I'm a PA and the host, and today we have Jonathan Baker. Jonathan is a colorectal surgery PA and sexual health. And Jonathan's so nice. Has been so nice and kind to come in, especially right after he just got off work. He's actually still at work, as you can see. So we're so grateful and thankful for Jonathan coming on tonight. Thank you, Jonathan.
Thank you for having me. Oh my gosh, my stuff just left, so I can actually take my mask off finally. All right, there's my face.
Yay! Thank you so much. We're so grateful that you took the time out of your day, especially right after work. I'm sure you're exhausted to come and talk to all the pre-PA students and give them some insight on your profession.
Absolutely, but I'm so excited to be here. We all just drop where you're coming from in the chat.
Yeah, great. Where are you all of you from or watching from? Alrighty. So as they do that, I'm going to take some time to get to know Jonathan a little bit. Can you first start off by telling us a little bit about your PA journey? How did you find out about the PA profession? How long you've been a PA, and what made you decide to become a PA?
Yes, I am excited to share that. So I'm in New York City, which I'm seeing show up in the chat quite a bit here, which is great. Best place in the world. And I'm originally from Cleveland, Ohio, and my mom was a nurse. Actually, she wasn't. She went to nursing school, and there was too many nurses when she graduated, which I think is the only time that's ever happened. There's like always a need for nurses, and for some reason at that point there wasn't. But anyways, she was doing her like clinical rotations for nursing school in my maybe junior year of college, and I knew I wanted to be in medicine. I thought I wanted to be a surgeon, and she was like, you know what, you should really look into this physician assistant, and like see if that's what you might want to do. And so I looked into it, and I was like, so I can do everything that I want to do and go to less school, and I can switch specialties. It just seemed like an absolute no-brainer. And so I was so fortunate to apply my senior year of college to a 2+3 program or 3+2 program. And so I got accepted into PA school like at the same time I got into college, knowing that I would graduate at, I think it was 22 when I graduated with my master's and started practicing medicine.
Oh, hold on. That is so impressive because one, I'm so happy that you learned about it so early on because yes. I didn't find out about the profession until I was actually in college. And I think that's the case for a lot of people since it's still like a relatively new career. But that's so cool that at 22 you had a master's. How was that? Like working at such a young age, and I'm sure everybody thought you were a baby. People still think I'm like 12. So how was that being 22 and out in the field and making like all that money?
Oh my God, that was like the coolest part, right? All my friends were in their like starting jobs, making like I don't know 30,000 or something, and I was like at least double that. Which if I graduated now would be like triple that. But you know, I never had problems with patients. Like you would think having this 22-year-old walk in and be like, okay, I'm going to biopsy you now, like that they would have a problem with that. And they were totally fine. And we'll get into this conversation, but I work largely with a gay population, which I also identify as. And so I think that sort of sense of community overrode what might be concerns about my age as they were seeing me. I think they were so comfortable to know that they were sort of with someone who understood where they were coming from and what was happening, that they were okay with the fact that I was like 4 years old.
That's awesome. So, how long have you been a PA?
So I'm in my 11th year.
Wow. Wow.
Yeah,
Amazing. Amazing. That's great. So, have you always been in colorectal surgery?
I have. So
Okay.
when it came down to it, my two biggest motivations for doing PA school were I wanted to be able to have a family. And here I am 11 years into my career, and I've been with my partner for 10 years with absolutely no plans of starting a family right now. And the other reason was because I wanted the flexibility, and I knew that I would never stay in one specialty. Like I knew that I would want to do all kinds of different things and go different places. And I've now done colorectal surgery for 11 years at two different practices. So all of my reasons for going to PA school actually ended up not coming true. But I regret for a second. It's been a really great journey.
Wow. So, what made you fall in love with the specialty and kind of just stick with it?
So it really comes to that community piece of it. So when I was in my PA school, we did a master's thesis, which I think now gets called the capstone project. And my topic was anal because it was something affecting gay men. And it was something that I really didn't know anything about. We didn't learn about it. I think one of my teachers mentioned it one time, and I was like, oh, that's interesting. And did some research on it, and I thought it was really fascinating. I had every plan to leave Pittsburgh, which is where I was living at the time. I went to Duquesne University in Pittsburgh, and I was planning to leave Pittsburgh, and a job fell into my lap doing what I do now with someone who had a particular interest in anal HPV among gay men, especially those living with HIV. And then along with that sort of comes the colorectal piece, right? We can't just do only anal HPV. And so I just sort of fell into it. And then from there, I get to serve my community. I get to, someone walks through the door with me, and we already have 10 things in common. And they're so comforted to just be with someone who understands their situation and where they're coming from.
Right. Yeah, I was gonna say that that's an amazing story to start with, and just being in that community, and especially identifying as a minority, it's like really different to have someone that looks like you or that has a similar story and background as you, and the patient provider dynamic kind of shifts. It's so different because they're more relaxed. Well, it just comes off that when they know that you share similar experiences, they're just more relaxed and they're more inclined to share their history with you and trust you more. Is that what you experienced too? Because I feel like that with my patients.
And sometimes they share too much history with me because they're comfortable. That's okay. That's okay. Sometimes we need too much history.
That's very true. So can you tell us about like a day in the life from when you get into work to now when you've clocked out?
Yeah. So I work 9 to 5 Monday through Friday, basically, except for Mondays. I work till 7. Fridays I get out a little early. And I really love that. That means that all of my friends who work in different industries, who also work 9 to 5, so I get to hang out with them on weekends and evenings, except for the last 9 months where I haven't got to see much of anyone. And so I have my own panel of patients every day. I never work directly with either of the two physicians who I work with. I do a ton of procedures. So lots of like biopsies, burning things, chopping things off. And so that gives me the luxury of seeing patients every 20 to 30 minutes. There's a lot of PAs are seeing patients every 15 minutes, every 10 minutes, every 8 minutes. So I'm really fortunate to get to have that extra time to spend with my patients because I'm doing procedures for the most part. So I'll see my patients through the morning for usually about 3 or 4 hours, do majority procedures, a couple of follow-up visits. And then I have a big pile of labs of patients who I have to call. And so I have like a 2-hour break in the middle of the day where I'll do all my phone calls, and a lot of what these labs might come back as our biopsy results, where I might have diagnosed a patient with like a precancerous area that we can treat. Very rarely do we actually find a cancer. A lot of STI results. So I'm calling patients with gonorrhea and chlamydia. I had about 10 of them today. So social distancing is not happening everywhere. And then I'll see patients for the rest of the day. So this afternoon, I saw actually a bunch of cancellations. So I probably saw about 6 or 7 patients this afternoon. I have my own room for the most part where I see my patients. I think I said hi to the one surgeon who was here today one time. Here and there, we might like have lunch or something, but other than that, I really don't see them. Maybe once every month, I bring the surgeon in for a second opinion on something that I don't know about. But I'm really quite autonomous in this role, and the surgeons who I work with really trust me. And I've built that up over being here for 6 years.
Right. I'm glad you mentioned that, because now they see that it doesn't really matter with any specialty. With a lot of specialties, you just work autonomously. Like you may barely work with a physician. They're there when you need them, but you're basically by yourself. But did it always start out that way? I'm sure like you were like relying on them more, or consulting with them more when you first started. But now that you have like 11 years in, you're basically on your own.
Yeah. My first 6 months at my first job was like direct supervision, basically. And I had the surgeon. He was not a surgeon. It was an infectious disease because we were focused on HPV. And so he was like over my shoulder, or I was watching him for like the first 6 months. And there was a lot of procedures to learn. So that was probably a longer training period than most PAs would have. But I had to learn all the procedures as well. And then sort of let me fly solo with the option to talk to him whenever I needed anything, which was really minimal. And I always like to share this because it's one of these things that I think everyone can learn from. I had my first annual review with him, and I was like, wow, I'm doing such a great job. My patients love me, blah, 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 blah. And I go in, and he was like, so number one, you've only asked me to see about 3 patients. You've been practicing less than a year, and that really, really scares me. And I was totally blindsided by it. I was like, wait, what? I thought I was like doing great here. And so it was a really big learning moment there of like, no one practices medicine on their own. No one's truly autonomous. None of us have the skills to be someone's full medical provider. We refer to other providers. We ask questions of other providers. And so it's really important that, even though you have the skills to be an autonomous provider, you're still relying on the others in your team. And especially with that collaborating physician where they actually have liability for what we do a lot of times. And so you really want to be working with them, and don't be afraid to ask questions, and don't be afraid, especially in your first couple of years of practicing, you can really rely on them.
Yes, that you just dropped some gems. Thank you for that. So someone had a great question. They asked, how has your practice changed? Are you seeing more telehealth patients, or how has it been since COVID?
So we're right in Manhattan. The practice closed down March 13th or whatever, like right when the fad. And the practice closed. We switched to telehealth like very spur of the moment. Like we had never done a telehealth visit in our lives. None of the providers have. We didn't know anything about billing. And it was actually a cool opportunity because I'm really looped in with a lot of things, with a lot of PA organizations, with a lot of medical organizations. And so all of these different practices were switching, and I was getting stuff in my inbox just constantly. And I was like, I'm just gonna grab this by the horns and run with it. And so I actually ended up writing up our telemedicine plan. I wrote up like our templates that we would use to talk about getting consent from patients, the template we would use for doing a physical exam over video. and took that task on, and my practice was so grateful for me doing that. And the surgeons participated as well, but I really kind of took the lead on it. And it was a cool opportunity to show my ability to be part of the practice and contribute something really, really meaningful in that way. And so we did telemedicine for about 6 weeks. I maybe saw one patient a day. You can imagine in colorectal surgery, there's not a whole lot that you can do via telemed. And I think telemed's a really, really great resource. It just doesn't really fit for me all that well. And so just one example, I had a patient who was having some discomfort and bleeding anally, and ultimately ended up having warts. And, what we did was he turned his camera down and turned around and pulled the pants down. And I said, "Oh, you need to back up more. It's fuzzy. Like the resolution's not great." And this was what we did. But it was like that, or he was going to have to go to an emergency room or somewhere that was just like absolutely loaded with COVID patients. And so for about 6 weeks, we did that. And then we came back into the office. And then I had my second opportunity where I went through all the CDC guidance and Department of Health guidance and figured out what we needed to do to legally see patients and make sure that we were adhering to all of the protocols that were required, and then how to go above and beyond and make sure that we had access to all the PPE we needed. And so between switching to telehealth and moving back in, I really had the chance to prove myself. And I don't know that I would have done that earlier in my career, but at this point I did. And I'm harping on that because, a lot of times as PAs, we don't think of ourselves as the leader of the team. But in this case, I really did get to be the leader of the team for those activities. And we couldn't have done it without my surgeons participating, but I really kind of took that on, and the practice was really grateful for that.
I'm sorry, it cut off at the end. After you said you really took that on, I'm sorry, my signal was a little fuzzy.
Oh, my microphone might be bad too. Can you hear me?
Yeah, I hear you.
Okay. And the practice was really, really grateful for my role in doing that. And I had the best annual review I've ever had this year.
Yeah, I'm sure that was amazing that you took the initiative to implement the telehealth and the plan for telehealth and how you all were going to safely see patients. That's amazing.
Yeah, it was a great experience. Now at this point, I'm not doing any telehealth. One of the surgeons who's a little bit older, and so he's in the practice very minimally and just doing telehealth for like new patients and kind of assessing if they really need to come in and when and what for.
Okay, nice. And do you ever have surgery days?
So I actually don't do any operating room surgery. Our practice is mostly procedures. And so that's like biopsies and burning things and that sort of stuff. And that's primarily what the surgeons do as well. Probably about once a month to twice a month, the surgeon will actually go to the hospital and do full operating room cases. I don't assist with those, and I actually have no desire to. I mentioned at the very beginning that I was like, I want to be a surgeon when I grow up, and I'll take this PA path. And I got into my first surgery on my I don't know, 5th rotation, and stood there for 12 hours and watched a surgery go down called a Whipple, which is a notoriously complicated surgery. And I walked out and I was like, all right, we got to refigure out what we're doing with our life, because it is not going to be surgery. And so I've sort of landed in this place where I'm a surgical PA, but I'm not doing OR cases, but I do procedures and injections and all that kind of stuff that's exciting about surgery without standing there for 12 hours and holding a retractor.
Right. Yeah, you don't have to first assist because you're doing it on your own.
Yep.
That's awesome. Okay, and we're going to get started with case studies soon, but I have one final question. I was wondering, is it solely colorectal health, or do you see other GI disorders?
So it is, we don't do GI. People do come in with GI stuff because they don't necessarily understand that gastrointestinal is different than colorectal surgery, but they really are different. We're sort of dealing with like anatomy versus like if someone's having like indigestion or that kind of thing, they really need to see a GI. So we work really closely with GI, and sometimes patients will come to us sort of thinking that we should be the ones managing their GI complaint, and I get them. Usually, I start them on something or say, you know, change this about your diet, but I want you to see this GI person. What we do adjacent to colorectal surgery is a lot of sexual health. And so I've mentioned a few times HPV. So HPV in the anus can cause cancer. And that cancer is really rare, but it's a lot more common among both gay men and people who are living with HIV. And so we do some procedures that can detect precancerous areas and treat those. We deal with anal warts a lot. And then anal sexually transmitted infections like gonorrhea or chlamydia or syphilis. And really, really frequently, those get undiagnosed or misdiagnosed at outside providers. A lot of times people aren't tested for rectal gonorrhea and chlamydia. They might not even realize that they should be tested for rectal gonorrhea and chlamydia. And so we get to do a lot of that. And then I get this really cool cohort of patients who I just absolutely love, who are maybe 19, 20, 21, and they develop anal warts. And it's their first medical problem outside of their pediatrician, outside of their parents coming to the doctor with them, right? And they're totally lost. And they're like, I have this health insurance card my employer gave me. I don't know where to go. And their friend refers them to us. And they're like totally scared. And then they come in and I'm their provider. And talk to them just like I'm talking to you now, like very casual. And by the end, they're like comfortable. And then they end up sort of like latching onto me, like wanting me to be their primary care. And I'm like, I can't do that. Like that's not appropriate. I'm your anal specialist. I'm not your primary care. And so we'll end up like screening them for STIs every few months. We might start them on medications for HIV prevention and different things. And then ultimately I'll turf them off to one of my friends who's in primary care who I know will take good care of them. But it's kind of nice to be there to like be that person to hold their hand through that first really terrible experience.
That's so sweet. And I can see why your patients kind of just get super comfortable with you and ask you or talk too much. It's because you're really easy to talk to and you're so, you have such a non-judgmental and relaxing voice. I can tell you have amazing bedside manner.
Thank you. It's really, really important, when we're talking about sex and we're talking about really taboo stuff, right? Like anal sex is like the baseline of where we're starting at, which is already taboo. And then we're going leagues from there. So it's really important that I have this sort of calm demeanor and don't get people too like worked up and don't get them worried about, they're already worried. They don't need me to scare them anymore.
Yes, that's so important. And so I just wanted to, a lot of people are commenting that, they're so happy that we're discussing just LGBTQ plus health and the community. So do you disclose that to your patients to make them feel more comfortable?
I don't directly, unless they ask, and if they ask, I'm always open. It's such an odd thing because you really, as a provider, you're not there to like tell patients about your personal life, right?
Yeah, exactly. Right.
Like when you're doing a sexual history, like it's not appropriate for them to be like, okay, now what about you, right? So I like to put a couple symbols out there and sort of like make that fairly obvious. Our practice is somewhat notorious
like for your scrubs.
Yes. So my pronouns on my scrubs.
Right.
Sometimes we wear like a little rainbow pin. For December, I had like a little HIV red ribbon on. And I don't know, if you're a gay man and you meet me, it's not all that surprising that I'm also gay. So usually there's not too much confusion over the matter.
No, that's so amazing that you do all those things. And, just the little things count. Like, and it's going to go a long way with patients. Like, you're amazing.
Thank you.
You're super amazing. This is awesome. Everybody loves it. You're getting so many compliments.
Good. I think it's really, when I was applying for PA school and a PA student, and I think even my first couple of years practicing, let's just stop at PA school. Actually, I had no one to look up to. I actually remember thinking like, wow, this is groundbreaking. Like, I'm this gay person who's like getting my master's degree, and like, the thought that I even had this thought is kind of scary to me now. But like, I'm not going into interior design or like fashion design or like all of the other things that like the handful of gay people who I knew were doing, or going to theater or whatever. And there's such a great community. It's so strong. And I'm so excited to share that, because I know that there's other people like me who are looking at this and thinking like, is the PA profession actually supportive of sexual and gender minorities? And we've notoriously not done a great job with other minorities. And that's out there for the public to know now. But I do think that the PA profession actually has a lot of support for LGBTQ individuals. And I hope that I see more and more of us, because I think that, we are known for filling gaps in care, and a huge gap in care is sexual and gender minority health. So I think there's a lot of opportunity, and I think we're like just the people to fill that gap.
Yes, that's very true. And you actually work with the AAPA to do all of that, right? And I know there's the LGBTQ PA caucus, right?
Yeah. So some of those supports. I am a past president of the LBGT PA caucus. Which is such a great group. And when I found them, I was like, oh my gosh, these are my people. And that group does really awesome things at the AAPA conference, which is the national PA conference. There's always a whole day where there's a track of LGBT health, which is crazy. And I'm also in a role where I'm the AAPA liaison to GLAMA, which is Health Professionals Advancing LGBTQ Equality. Which is a group predominantly of physicians. And so AAPA has a couple of these liaison positions. And so I sort of work in between GLMA and AAPA, and I help to keep AAPA policy updated and make sure that we're sort of on the front line of that.
Wow. I'm actually trying to look for it, because I follow them on IG, so I can tell everybody the name of it. The Instagram page for the LGBTQ PA caucus. I'll find it and I'll let you guys know, so you guys can follow it.
I was like, I don't know what it is off the top of my head.
Yeah, I'll try to find it, but I'll let you guys know the Instagram name so you guys can follow the page. It's amazing. All right, so it's 7:30. We don't want to keep Jonathan on for too long, even though he's amazing. We can go on forever, but we're going to transition to do the case studies. If anyone wants to come on with Jonathan as he walks through the case studies and come on, just make sure you raise your hand. But we're going to give him a chance to start setting up and get ready to do the case studies. Fun. And I know you guys have a lot of questions. We're going to answer questions after the case study. Don't worry, I'm not ignoring you guys. There's so many questions.
There's so many questions. That chat is blowing up.
Yes. How do you raise your hand? There should be a button there. Let me make sure it's not turned off. You guys should be able to raise your hand. I can't see the button since I'm a presenter, but there should be a way to raise your hand. Come on. Yeah, request to speak. Alrighty. This presentation looks like it's going to be so cute. I love the black and pink. And and his Instagram name, when you guys put his Instagram, is Rectal Rockstar. So cute.
There's some questionable content on there. I'll be honest with you.
Hey, it's your IG.
That's right. I do talk about a lot of what we're talking about today on that, and I use it as actually one of my main platforms, and it reaches so many people. When I speak at a conference, I reach 100 people in the room. When I put something on Instagram, I reach several thousand people. So I love using it as a way to educate.
Yes, it's so important. That awareness is so important. Okay, guys, we'll get started. I hope the raise your hand button is working, because usually you guys have always requests to get on. Okay, so we're gonna get started, and if I see anybody raises their hand, then I'll bring them on to the presentation.
Perfect.
Okay.
All right, so I just have one case for you all, but it's a nice long case where we can talk about a lot of different stuff. So a 28-year-old presents with anal pain and bleeding. The patient's bowel movements are increasingly painful, and bright red blood is seen in the toilet following bowel movements. The patient tried preparation H, which burned. So what additional information do we need for this patient, and what should this patient do? So let's look at some things that I'm thinking about here. So the patient's presenting with anal pain and bleeding, and we'll talk about some things that can cause that. There's a whole lot of things that can cause that. Some of which are really benign, like wiping too much, some of which are not so benign, like anal cancer, and anything in between. So a big range of what we could be dealing with here. What else are we seeing? The patient tried preparation H. So this is really common. Patients really don't like to come in with anorectal complaints. And so they're going to do everything they can to try to treat this on their own. And a lot of times they'll find their one friend that they confide in and ask them what they can do. So I like to ask this question so I can see where patients are coming from.
It looks like, sorry to interrupt, it looks like Juliana is going to come on. So,
all right, Juliana.
Go through the case study with you. Just going to wait for her a little bit. Okay, hi, Juliana.
Hi.
Hi, Juliana.
Hello.
Thanks for coming on.
Thank you.
Where are you coming from?
Columbus, Ohio.
Columbus, great.
Mm-hmm.
And tell me about yourself.
I just got a job as a PCA, and I have my master's in anatomy, and now I'm applying to PA school.
Awesome. Well, thank you for joining me. So I presented a little bit about this patient. What other information do you think I would want to get from this patient?
Sorry, I didn't hear it. Let me read over this slide. I wasn't here when you were explaining it.
Okay. All right.
You could ask how long have they been seeing the bright red blood in their stool? Did they have like what kind of consistency was like the bowel movement, that type of thing, their diet, as well as like have they changed any like prescriptions recently, or can like drastically change their diet or something like that.
Really, really good. Absolutely. So all of that. We want to know what's going on with the bowel movements, things that might have changed that. And you hit the nail right here on the head. The things that commonly change bowel movements are new medications, big changes in diet. Stress is another really big factor. So we've seen a lot of different bowel movements since March. What else? Anything else here that we think we could ask this patient about?
Maybe like their sexual history or anything like that. Do they have a new partner?
You got it. So we definitely want to find out what might have caused this. We want to do a sexual history, find out, is the patient using their anus as a sexual organ? There's also a big piece of information missing from the first line where I describe the patient's basic demographics. Do you notice what's missing there?
Their sexual orientation.
Even before that.
I don't know.
So I haven't put a gender here for the patient at all.
Okay.
All right. So our patient says, as they're thinking, I want to go get seen by a healthcare professional, my ID doesn't match the name that I go by. Is the provider going to refer to me as he or she? Will I be judged for engaging in anal sex? Will I be turned away? Is that even legal? Will I be hurt or abused by the provider or staff? So LGBTQ individuals have a really long, terrible relationship with the healthcare industry. 56% of us have experienced healthcare discrimination. What's the statistic? About 1 out of 5 of us have been refused care. And if it's transgender, that number increases. And then if you compound that with other minority status, it gets even worse. And so once a patient's discriminated against, they're much more likely to not be seen again by a healthcare provider for a year. And that includes for their diabetes medication, their blood pressure medication. And then if that person who's already an LGBTQ minority is also a racial or ethnic minority, they're actually 3 times less likely to come back and be seen for their other health concerns. And when we say, will I be turned away, is that even legal? It unfortunately is. And this is something that's really up for a lot of debate. There was a huge Supreme Court decision made this year that actually challenged this federally for the first time in 2020. So prior to that decision, it was fairly black and white. If you were in certain states where you didn't have protections, you could literally be turned away from care at an emergency room because you're gay, lesbian, transgender. Here in New York, absolutely illegal. But in somewhere in the South, very possible. I have a friend who's a PA who lost his job in Kentucky because he was gay. That was their only reason. They didn't come up with any bullshit reason to fire him. So you're all seeing me. I'm clearly well adjusted. I'm in a great place in my life. I'm in New York City. I have a partner. But I'm not representing some of these patients who suffer pretty big disparities. So our patient comes in and they see my white coat, which I'm presently wearing scrubs with the same monogram on them with my pronouns. And so this patient knows right away that I'm someone who gets it. I'm someone who understands the importance of gender. I put this rainbow pin on. I use my pronouns not because I'm worried that anyone's going to misgender me, although it has happened in my life. And this, I think what's really unique about having your pronouns displayed is it's sort of a way to show that you're an ally or that you're part of the community. But it doesn't really out anyone. It doesn't really do anything. It's not a big, bright rainbow. It's just sort of this nice, safe way to suggest something to your patients and help reassure them. What happens with pronouns is I think sometimes they sort of get misused and abused when we're, in the world of Zoom, we're like, everyone share your pronouns. I don't know that we need to do that, but I want to always be in a space where patients can share their pronouns if they want to. So let's get into what's going on with this patient. Juliana, what are some things that you might think could cause rectal pain and bleeding?
If they have any type of if they lesion or something like that, whether it be like a very hard bowel movement or I'm brain blanking on the term, but when the veins rupture in the anus, my brain's blanking on the term.
Hemorrhoids.
And that's my first thought.
Perfect. Exactly where you should be. So I'm about to show you a bunch of really graphic pictures. If you do not want to see graphic pictures of anuses, now's a good time to not look at your screen. And just for reference, this is the camera that I'm using. It's a high-powered camera so that I can biopsy and burn really discrete areas. This is the perfect butt. So just to orient you at what we're looking at in these pictures, in the middle is the anal verge, which is the opening of the anus. Towards the top or posteriorly is towards the tailbone. Anteriorly is towards the perineum, which is the skin between the anus and the genitals, also called the taint. So this is what we're looking at. There's going to be times where the patient's on their side, but I'll keep you kind of oriented to what we're looking at. So the most common thing, and Juliana, you said if they're having hard bowel movements, and that's exactly what I'm thinking here for this patient. So they could have a little tear in the skin that might be caused by either a hard bowel movement or sometimes by sex. So an anal fissure is a linear tear at the anal verge or at the anal opening. And this is characteristically way more painful than the size of the lesion. So even though this is magnified, it's about a centimeter big, the patient feels like they're being stabbed by a knife when they go to the bathroom. And we can treat this with a number of ways, including prescription creams that I can send to their pharmacy. And ultimately, sometimes we actually treat this with a Botox injection, which relaxes the anal sphincter so that their fissure can heal. One of the most common reasons for pain and bleeding is just over wiping. We really like our butts to be clean. And so many of my patients over wipe and they just use dry toilet paper. And you can imagine if you're doing that on any of your skin over and over and over, you're going to eventually erode the skin. And this can get so severe that it causes pain and bleeding. Hemorrhoids, so these are the veins that you're talking about. So there's all these veins around the anus and rectum, as you know, as anatomy expert. And so these veins can become dilated. Externally like this, they tend to cause pain, but they don't usually bleed because they're under a really thick skin. Mm-hmm. Whereas internally, they're under just the rectal mucosa, which is really, really thin. And so these ones bleed really easily. And you can see these look like there's just blood coming right out of them. You talked about at the beginning that we should do a sexual history on this patient. That's super, super important for a number of reasons. One is they might be exposed to something like gonorrhea and chlamydia. And so actually rectal gonorrhea and chlamydia usually don't have any symptoms. So we screen a lot of patients who don't have any symptoms. We just test them to rule it out. But sometimes they do get severe symptoms. So this is looking through an anoscope, and you can see there's pus and blood and discharge. And it looks like everything you think a gross infection should look like. Syphilis is another infection that can affect the anal area. And that presents as a little painless ulceration. So even though this looks like the patient's probably in a terrible amount of pain, the patient's probably not. And that's really characteristic of syphilis. Herpes can cause really severe anal pain and sometimes bleeding. Herpes can appear in a lot of places and usually appears as a little blister. In the anal area, that blister bursts first. So you end up seeing like this ulcerated appearance like you see here. And what's interesting about anal herpes is it can be HSV1 or HSV2. So HSV1 is what we think of with oral herpes, like a cold sore. HSV2 is what we think of as genital herpes. On the anus, it's probably about 50-50, whether it's HSV1 or HSV2. We can also have anal warts. And warts typically aren't painful, but sometimes they'll get irritated, and they can be. They don't typically bleed, but sometimes, especially if they're internal, there can be some bleeding. What's really important about anal HPV is this second line on my last line on the screen. And this is a quote from the New York City Department of Health. Everyone who is sexually active will be exposed to HPV in their lifetime. So HPV is super stigmatized, but it's actually super, super common. We're all walking around with it, and we're just fortunate enough to not have developed warts from it. So once we treat this patient for the rectal pain and bleeding, now that we know that they're engaging in anal sex, what are some opportunities for preventive health for this patient? What can we screen them for or vaccinate them for, or what preventive health opportunities can you think of, Juliana?
Well, isn't there a vaccine for HPV?
There is. What else? Anything else?
Just like sexual health, making sure you're using like protection as best you can, and I guess like lubrication if need be type thing.
Perfect. So we want to routinely screen this patient for STIs. I mentioned rectal gonorrhea and chlamydia usually don't have symptoms. A lot of offices just test with a urine sample, and that's only looking for genital infections. Whereas you see these two blue swabs, we're going to also want to test their mouth and their anus if they're having sex using their anus. Vaccination, you hit the nail on the head there. So HPV vaccination is recommended for everyone up to age 26. And then that recently got extended up to age 45. And there's no recommendation to repeat HPV vaccination. It's one set of vaccines and done. It's immunity is good for life. I talked a little bit about anal precancer that we can diagnose and treat. And so we can actually do a test called an anal pap, which is very similar to the gynecologic pap that's done in the cervix. And this can only really should be done if there's a provider to send the patient to. So if you have a patient in New York City, you can do an anal pap on them and send them to me. If you're in Kentucky, where my friend got fired, there's no one there who can follow up on an abnormal anal pap, so don't do one.
Can I ask a question?
Yeah.
Is like anal cancer, is that somewhat more common there just because of the transitioning like epithelial tissue?
It is. So really great question.
Perfect.
So what happens in the cervix, which is where we do a gynecologic cervical pap smear, the cervix, there's a transition of tissue where you have like thick skin-like tissue of the vagina, and then you have the thin tissue of the uterus. And the same exact thing happens in the anus. You have the thick tissue of the anus and the thin tissue of the rectum, and you have a very similar transition zone. And so we actually stole everything from the gynecologists. We do a pap smear in a similar way. We diagnose lesions that look very similar in the anus as they do to the cervix. And in fact, when I do a pap smear, if I sent it to the lab and told them it was a cervix, they wouldn't know the difference because the tissue is that similar. So one other opportunity with this patient is HIV prevention. And you talked a little bit about protection for the patient. So anal sex is the highest risk for sexual transmission of HIV. And on this chart, you can see the receptive anal partner risk just skyrockets, way more than anyone else. So versus like penile vaginal sex, you see it's way, way, way higher. And so we want to prevent HIV in anyone who's using their anus as a sexual organ. And that's not just going to be in your sexual and gender minorities. This is among 20,000 US citizens who report being heterosexual, and about 30% report that they engage in anal intercourse, and the majority don't use condoms. So a lot of times condoms are used for contraception or prevention of pregnancy, and people may not think about them for prevention of HIV, even though that's the place where they're most likely to get it. And so I often prescribe a medication called PrEP, or pre-exposure prophylaxis. And this is medication that people can take daily to prevent their risk of getting HIV. It's extremely effective, over 99% effective. And there's a study that showed that it was safer than aspirin, that you're more likely to have significant side effects from aspirin than you would be from any of these drugs that are available as PrEP. And this is an expanding field that I'm really excited about. There's recent data that came out about an injectable that can be given every 2 months. And I think we'll ultimately see the same thing as we do with contraception, where there's all kinds of different options where patients can pick what works for them. So that is my case here. I know there's a million questions. Juliana, thank you so much for joining me.
You're amazing. You're a lot of fun to listen to.
Thank you. Thank you.
Thank you.
Thank you, Juliana. Thank you so much for coming on. Thank you so much, Jonathan, for that presentation. That was great. I actually learned a lot from it. So thank you.
Every time I present, people learn a lot just because it's like a part of the body no one ever looks at or thinks about. And then what's scary is there's so many people having anal sex and they never think about their anus otherwise. So a lot of opportunity for learning for sure.
Definitely. I had a question when you talked about PrEP. Do you work closely with the infectious disease doctor, or like have one? I know probably not one at your practice, but like one that you consult with or refer patients to.
So I have infectious disease primary care is sort of like a field that didn't really exist. So people who are living with HIV typically take one pill once a day. It completely suppresses their virus, which means they can't transmit HIV sexually. I'll say that again. If their virus is suppressed on medication, they cannot sexually transmit HIV. So they're taking one pill once a day.
That's very true.
Yes. They take one pill a day. They do really well. And so their infectious disease specialists have really turned into like their primary care providers. So there's this huge overlap there. So all of my primary cares that I send patients to are people who can manage HIV and can manage the HIV medications that are used as PrEP. But I had mentioned at the beginning, those like young patients who come in and have anal warts for the first time, and I'm taking care of them. So I actually usually start them on PrEP. Even though it's like so far outside of the scope of a surgical practice, if I can start them on PrEP, you know, and save them 3 months of potential risk, like I really believe that I've prevented many HIV infections in that context, you know. And this is someone who has anal warts, so we know they're using their anus for sex, and that means that they're at really high risk. It's so easy to prescribe. And that's actually another thing that I brought to this practice with me. I had some experience with that in my prior job. And I asked the surgeon, you know, do you mind if I do this? And he said, go for it. And usually when he starts patients on PrEP, he'll have them talk to me for about 5 minutes first, then I'll send the prescription for them. So another place where I've really got to add something to my practice as a PA.
That's amazing. So the first question we have, I'm sure I can answer this, but I'll let you answer it. Is can anyone be put on PrEP?
Yes. So anyone can be put on PrEP. Not anyone. I think the youngest approval is like age 12, which lots of people have their sexual debut before 12. It is appropriate for men, women, and anyone in between. There's certain regimens that you might avoid in someone who is exposed to HIV through a vaginal route. For whatever reason, PrEP just happens to accumulate in the rectum and be there right where we need it when we need it. And I have patients from age 18 up to age probably 75 who are on PrEP. Super safe, super effective, and something that I hope to see more and more of.
Thank you for that. Someone asked, how often do patients refuse your treatment options, and what advice do you offer them, or how may you like convince them that, you know, they should go ahead and do that specific treatment?
That's a great question, and that's such a hard thing to manage. You know, we all go into healthcare because we want to help people, and you know, when you see a patient, like you already know so much more than they do about whatever their condition is. But people have concerns for a lot of different reasons, and some of them are valid and some of them are not valid. But in reality, if the patient has that concern, it's valid either way, even if it's completely based in lies and deceit. Like, it's still their feeling. And so I'm very, as you can imagine, I'm not very aggressive. I don't push patients into any treatment thing. If they came in with warts and I'm like, let's treat these, and they're like, I don't want to, then I'll typically, be like, here's the options. Let me just run it through with you, and let's see you back in a month and see where things are at. And sometimes they like to try herbal remedies, which are not very successful. And that's okay. I'll meet them where they're at. If they want to try something first, or if their friend recommended something and that's what they want to do, that's okay with me. I use a lot of facts. I use as many statistics as I possibly can without confusing people. So if we're talking about like anal precancer, I'll say, in the course of 5 years, 1 out of 300 of these will become cancer, which is not very likely. And so if you want to wait and delay it, that's okay with me, but let's watch you closely. But it's really, you don't want to force patients to do anything, and you can't. Because if I say, nope, we're scheduling you for anal wart surgery, and they don't want to do it, guess if they're going to show up on the day of their surgery? They're not, right? So it's all about meeting patients where they're at. Sometimes I'll explore where their concerns come from. There was, I think a lot of people have heard about the Tuskegee syphilis trials. So, there was a time period where we let a bunch of racial minority men run around with syphilis when we had a treatment available to them. It affected their brains, it affected organs in ways that cannot be fixed. And we had a treatment that was a simple injection of penicillin. And that was 50 years ago, something like that. I don't care. Like that's still in someone's brain. That's still in someone's parents' brain. They came up with that story. Of course they distrust me. And maybe they went to a provider before them who was a jerk. And maybe they went to someone who tried to force them to do something they didn't do. Or maybe they got turned away at their last provider. So I'm not going to judge them if they don't want treatment. I'm going to try and meet them where they're at. And I'm going to let them accept that treatment on their own terms and timing.
Yes, thank you. That's a great answer. And the Tuskegee syphilis trials was terrible, and I'm glad you mentioned that. I'm so glad you mentioned that, because that's where a lot of distrust comes from. I mean, that and all other experiments that were done on Blacks and minorities. That's a lot of where the distrust in the medical system comes from patients. So it's going to take a while for them to fully trust us, but it's all about that patient-provider relationship.
Yeah. And there's just countless other examples, and there's literature coming out right now about how the pulse ox, which is a simple test, you put a device in your finger to check oxygen, that is actually totally based on white people, and for a person of color, that number could be totally different. And I haven't read that paper yet, but it's like this stuff's still happening now. Like we're still basing medicine on heterosexual, cisgender, white, older men. and the other population we just extrapolate to. It's terrible.
Yeah, thank you so much. And speaking of that, someone said mental health is such an important topic at this time, and it can affect the LGBTQ population in a different way. LGBTQ members of the community can also intersect with race, religion, ethnicity, nationality, and socioeconomic class. What advice can you give to another provider to better support these type of patients?
That is a great question. You are speaking my language.
Thank you, Connie. Thank you, Connie.
Oh my gosh. Yeah. So it's actually really interesting. When you look at someone like me, my parents were fairly accepting when I grew up. I have a circle of friends who are gay. I still would go to my family for holidays if I were allowed to travel. And I've been affirmed every step of the way. I'm out at work. I'm out to my employer. I'm out to my patients. I'm out to my colleagues. My risk of a mental health concern would be exactly the same as a heterosexual peer. Maybe not exactly the same, but pretty damn close. And then when you start to pull those pieces away, when you have a family that's not affirming, when you don't have social support, when you don't have a friend circle, when you don't have stable housing, when you don't have a stable job, or you don't have a job that you can be yourself at, each time you pull away one of those little pieces, the mental health disparity increases. And then where it gets really bad is when you have someone who's bisexual and they don't have a gay community and they don't have a straight community. They just miss out on having that community. And then it gets even worse when you have someone who's like kind of bisexual. Like if they are mostly heterosexual, but they definitely have some same-sex desires, then you have someone who can't disclose that to anyone. They tend to keep it bottled up. And those are the people who have huge rates of depression, anxiety, personality disorders. And these things bubble up when they have to keep that in. So it affects across the spectrum of LGBTQ. But when you look at the role that community plays in that person's life, it makes a massive, massive difference.
Yes, you just dropping gems and just educating all of us. Yes, thank you. Thank you so much for that. So, more questions. Let's see. Sorry, just scrolling through.
So can I this wasn't a question, but I'm saying this all throughout the chat right now.
Yeah.
Is someone saying always use condoms for sex, always use protection. So the CDC redefined the word protection in 2015 to no longer exclusively mean condoms. So condoms are really great, right? They prevent a lot of things. But the reality is that PrEP is actually more effective against HIV than condoms are. Condoms slip, they break, they don't get used for a number of reasons. Sometimes you can't negotiate it, depending on your relationship status. If you're a commercial sex worker, there's lots of times where condoms are simply not the answer. And what I love about PrEP is it puts that protection in your own hands. So I can take my pill every day and I know that I'm protected from HIV. And if my partner is abusive and won't use a condom, and I'm stuck in that relationship for whatever number of reasons or variables, I still have a way of protecting myself. So condoms are really great, but the condom only message has got to go. There's more to sexual health than that.
Yes. So, oh my gosh, I'm so glad that you mentioned that, and I'm so glad that you have you just consider all these different patient scenarios and profiles and personalities, and take into consideration their social statuses and social norms, social stigmas. And I'm so glad that because you said, oh, if they're a sex worker, if they're in an abusive relationship, if this, if that, like there's not one patient profile. Like, you never know what someone's going through, what may cause them to not use a condom. And it's just having that non-judgmental thinking. Like, I love that. I love that you're like that.
So I know we're coming up on time. So I already regret what I'm about to offer here, but I'm going to put an Ask Me Anything on my Instagram, my story.
It's 8:00. I didn't even realize that.
Right. And let's chat for a couple more minutes, but I'm going to put that up there. And so you can put whatever questions you want in there. Based on what this chat looks like, I'm not going to get to everything, but I will respond to as much as I can. I really, I see some people are leaving too. So I really appreciate everyone coming to this and sticking around and staying. I really love doing these virtual shadowings because I get to share just a completely different perspective. And I'm a gay man. I'm in New York. I have gay patients, and that's great. But what I would love is if your primary care provider in Kentucky was listening to me and took these bits of knowledge with them and use that in their primary care, and that the gynecologist in Atlanta is doing the same thing, and that the dermatologist in Colorado is doing the same thing. These things I'm talking about apply across the spectrum. I just happen to be in a nice little insulated area where it's part of my everyday. But I really hope that as you apply to PA school and become PA students and become PAs and become my colleagues, that you'll remember all of these things and take that with you and educate your colleagues. And remember how powerful PAs are. Remember those stories that I told you about bringing PrEP to my practice and taking telemedicine and getting ready for reopening after COVID. All of that through a PA when there's two physicians that own the practice. And here I am, the one writing up the protocols for that. It's an awesome, awesome profession. You're all on a great track, and I can't wait to call you all my colleagues.
Thank you so much. I'm so sorry I went past 8:00. Thank you so much. I cannot thank you enough. This session was amazing. It was an eye opener. You dropped so many gems. You said so many important things for us to know, just moving forward with our careers, for myself as a PA and for our future PAs. Thank you so much. And thank you for the work that you do with the AAPA, trying to shape our profession. Thank you so much. You guys follow him on Instagram. He is going to accept questions at Rectal Rockstar. I put it in the chat, and we won't keep him for too long. Thank you again, Jonathan.
Thank you so much for having me, Rodolin.
It was
This was
great
an
having
awesome
you.
experience.
Thank you.
And next time you're in New York, when there's not a pandemic, we're going to connect.
Yes.
Okay?
Yes, I will. We will.